Hello and welcome to Assessing Fitness to Detain in Police Custody. My name's Matt Peel. I'm a custody nurse and also a UKAFN steering group member. That's the United Kingdom Association of Forensic Nurses and Paramedics. As well as that, I'm also a master's student doing the Advanced Forensic Practice course, focusing on custody at Staffordshire University. Welcome. This is UKAFN's first ever webinar. We are very hopeful that if it's successful, we'll have more to follow, but they will be specifically for just the UKAFN members. If you are not a member of UKAFN, well, you can join today if you visit www.ukafn.org. UKAFN, or the United Kingdom Association of Forensic Nurses and Paramedics, is the UK's leading association for forensic healthcare specialists. And we bring together forensic practitioners from across the country. And the aim of UKAFN is to raise awareness of the work of forensic practitioners and to improve access to them. This includes custody nurses, custody paramedics, sexual assault nurse examiners, forensic nurse or paramedic examiners. At UKAFN, we are committed to raising the awareness and profile of forensic healthcare practitioners, working together to develop, improve and maintain a high standard of forensic evidence collection, and providing high quality practitioner care for all individuals in a holistic manner. And that's working in partnership with the relevant government bodies and all forensic collection specialists, including the physicians and the police. So the aims of today, is to discuss the role of the custody nurse, custody paramedic, to discuss the purpose of the fitness to detain assessment, discuss how to undertake a high quality fitness to detain assessment, and also discuss the management of some acute and chronic conditions within the custody setting, whilst ensuring that the detainee's rights and welfare needs are maintained. So the custody nurse paramedic obviously has to be registered with the relevant professional body. They should have several years post-registration experience, and really this wants to include some kind of urgent care, accident and emergency, walk-in centre, acute assessment unit, medical assessment unit, GP out of hours, ambulance service, some contact or experience with substance misuse, contact or experience with mental health or primary care. Now, the role within custody as a custody nurse or custody paramedic is a role that is an advanced role. The role is at an advanced practice level. It requires nurses and paramedics to operate at a level that is well beyond that of their initial registration. Nurses and paramedics will be diagnosing and treating individuals with a wide range of undiagnosed and undifferentiated conditions. They will be undertaking and completing whole episodes of care both independently and without supervision. Recently, the Staffordshire University introduced the Custody Healthcare Practitioner Induction Qualification. This is a 15 credit module at level 6, which is degree level, and lasts 15 weeks. It costs £150 and there is no university attendance required. Students will provide a profile of evidence which includes 5 pieces of reflection, and there will be a Viva exam. This is just an induction qualification. It must be stressed that Staffordshire University doesn't deliver the induction. This just accredits an induction that's already been provided by the forensic healthcare provider. The further course, the one that I'm currently undertaking at the moment, is the Advanced Forensic Practice programme. Again, currently only at Staffordshire University. And there are 3 levels: postgraduate certificate, postgraduate diploma and the masters. So the postgraduate certificate includes the introduction of forensic practice, professional legal skills for non-lawyers, and advanced clinical forensic practice in police custody. Students completing the postgraduate certificate will be awarded the asset certificate. That's the UKAFN asset, which is Advanced Standards in Education and Training. And the FFLM, in their guidelines, recommend that nurses and paramedics working in custody within 3 years should achieve the asset or the postgraduate certificate in advanced forensic practice. The postgraduate diploma goes on to deliver some physical examination skills, research methodology, and other options, and then the final master's is delivered by a master's dissertation or a project-based change. So, PACE, the Police and Criminal Evidence Act and Custody. The Police and Criminal Evidence Act, the clock generally starts when the detainee arrives in custody. PACE generally allows for 24 hours detention without charge, and the PACE clock is paused when a detainee goes to hospital. A police superintendent can authorise a further extension of 12 hours, after which the police can apply to a magistrate for up to a further 36 hours. So the total time to be held in custody without charge is 96 hours, with the exception of terrorism, which is under different legislation. Now, the detainee has rights while they're in custody. They have the right to have someone informed of their arrest, but it's not America, they do not have a right to a phone call. They have the right to consult privately with a solicitor and to receive free and independent legal advice. They also have the right to consult the Police and Criminal Evidence Act Codes of Practice, or PACE Codes of Practice, which sets out the police powers and responsibilities. Now, the condition in which they should be detained should be that of a reasonable standard of comfort. They should be afforded adequate food and drink, which meets any special dietary needs, and have access to toilet and wash facilities. They should have suitable clothing, and they are entitled to medical attention if requested, as well as exercise when practicable. Nurses and paramedics working in police custody are considered to have a potentially conflicting roles, because there is the HCP who has, first of all, a therapeutic relationship with their patients. So there's the HCP and patient relationship. But they also have another role as a medical legal advisor for the police, so they're advising on fitness to detain, fitness to interview, etc. And then thirdly, they also acting as an independent assessor of injuries that may have been caused by the police, so examining a complaint that has been made against the police. So three very different conflicting roles. Healthcare needs within police custody. Well, the commissioning of police custody healthcare was intended to transfer to the National Health Service in April 2016, and that's bringing it in line with the rest of the criminal justice service. However, this was stopped, and commissioning now will, for at least the next 5 years, remain the responsibility of the relevant police forces. I think it's widely accepted amongst the forensic profession that this is really a disappointing decision and really a missed opportunity for forensic healthcare, police healthcare specifically. So the healthcare needs of people detained in police custody, well, 90% of those DPs that are referred to healthcare are referred for an assessment of their fitness to detain. Previous studies have demonstrated that between 28 and 41% of detainees in police custody are referred to healthcare. However, information obtained by UKAFN using Freedom of Information requests highlighted that during 2015 it was on average 50% of detainees that were referred to healthcare, but the frequency varied between 19 to 95% depending on different geographical police forces. And of these calls, nurses and paramedics assessed 69% of all calls, compared to 31% by the forensic medical examiner. So the prevalence of comorbidities amongst the detained population is disproportionately high to that of the general public. The prevalence of substance misuse is again disproportionately high amongst the detained population, and this really leads to a complex mix of physical illness, mental illness, social problems and learning disabilities within the police custody setting. Now, the standard of healthcare within police custody, well, detainees can expect a standard of care that is comparable to the NHS. Detainees should be treated as they would outside of custody, and any established prescribed medication should be continued where possible. Consent is fundamental with healthcare, and a detainee is entitled to consent or refuse a clinical assessment. The Mental Capacity Act 2005 applies in police custody, and there is a presumption of capacity. Consent should be fully informed to be valid, and the detainee must be informed that there is no absolute confidentiality. Consent should be given without undue influence of the police or coercion from the police, and written consent is preferred but is not necessary. So what does PACE say about healthcare? Well, the custody officer must make sure a detainee receives appropriate clinical attention as soon as reasonably practicable if the person appears to be suffering from a physical illness, is injured, appears to be suffering from a mental disorder, or otherwise appears to need some clinical attention. And that's out in the Codes of Practice, section C. Now, underlined is suffering, and I think this is, quite ambiguous. Some people feel that suffering is that they have a diagnosis of. Some people will interpret suffering as they are unwell. And that might explain why, on the earlier slide, some areas are referring 19% of their detainees and some are referring upwards of 90% of their detainees to the healthcare. So coming on to fitness to detain, the Codes of Practice also recommend seeking clinical attention if somebody is suffering from a minor injury or illness, appears to be suffering from an infectious disease or condition, a detainee is requesting to be seen, they require some prescribed medication, or they have in their possession or claim to need medication for a heart condition, epilepsy, or another condition of comparable seriousness. Now, the purpose of the fitness to detain assessment is to assess and manage any illness or injury, assess and manage any drug or alcohol intoxication or withdrawal, assess and advise on the mental state and self-harm risk of a detainee, and advise the custody officer on how they can best care for the detainee, as well as assessing the need for the continuation of regular medication and, if appropriate or where appropriate, authorise its use. And you may need to recommend a medical rest period, a period of rest where clinically indicated. And you also recommend a level of observation. And it's highlighted that you make the recommendation, but the ultimate decision lies with the custody officer or the custody sergeant. Finally, to identify those detainees who are not fit to detain in police custody and assist with arrangements regarding their appropriate diversion from custody, most likely to the emergency department. So, what are your responsibilities as a healthcare professional in delivering the fitness to detain assessment? Well, first of all, you must practice good care, treating everyone with courtesy and respect, which is a given. The health and safety and well-being of a detainee should be paramount, and this really overrides any forensic implications. As discussed, you want to get valid, informed consent, and you want to respect confidentiality, which is as far as possible, as well as providing instructions to the custody sergeant, custody officer, both verbally and in writing. So, assessing fitness to detain, well, the general principles of clinical examination apply, and those are that history first, followed by the clinical examination. First off, you want to get some collateral history from the police, including the time of arrest, the alleged offence, any concerns that have been raised by the police, and the level of force used on arrest or subsequently since they've arrived in police custody. It's important to note the alleged offence because more serious offences are going to be associated with a much longer detention, as well as some offences are much more associated with mental illness. You want to ascertain the presence of any injuries. And taking a history from the detainee will depend on the reason for the referral. So if a detainee has been referred for a specific problem, this is really what should be explored at the outset. So that's the presenting complaint or the custody sergeant's concerns. And then you want to have a look at the history of the presenting complaint or concerns. And a useful acronym is SOCRATES, which is to explore a complaint, which is site, onset, character, radiation, association, timing, exacerbation, and relieving factors and severity. And I think this slide just sums it up nicely. It's a nice little infogram slide, just setting out that site, onset, character, radiation, associated symptoms, time, cause, exacerbating factors, and severity. So carrying on, you want to establish your past medical history, and you want to ask specifically about a couple of things about asthma, diabetes, epilepsy, heart conditions, and any previous major surgery, or if indeed they've seen a doctor for anything at the moment. That's because these are the type of serious conditions that can cause somebody to become quite unwell quite quickly in police custody. You want to establish their mental health history. Again, specifically asking about any history of mental illness, either major or minor, whether they've had any formal or informal psychiatric admission, so that's whether they were sectioned or it was an involuntary admission. And you want to know when they were admitted, where they were admitted, why they were admitted, and for how long. Are they currently engaged with any community mental health services? And what's really important to assessing police custody is thoughts of self-harm or suicide. So are there any recent or current thoughts of self-harm or suicide? Or has there been some more remote thoughts or attempts at suicide? You want to establish somebody's drug history. This is really important because it can highlight some past medical history that has not already been disclosed. But you specifically want to ask about prescribed medication that they're taking, prescribed medication that they should be taking but they're not taking, any over-the-counter medication, herbal medication, borrowed medication from the mum, the brother, their auntie, any street-bought medication, which is usually high-value prescription-only medication. This is the type of things like your Zopiclone, your pregabalins, your gabapentins, that, occasionally Subutex, methadone, those type of drugs. And you want to know the timing of the medication, when they were last taken, when they're next due, and the location of the medication to see if you're able to collect it. And as always important, always check allergies. You want to establish the detainee's alcohol history, and you want to specifically ask about the amount of alcohol that's been consumed in the last 24 hours, the time of the last had a drink, or their average alcohol consumption. And then there's also the cage questions. We'll come on to that in a second, but a score of 2 or more suggests some alcohol dependency, and certainly somebody who is at risk of alcohol withdrawal. Ask somebody how long they can go without alcohol and what happens when they do go without alcohol. The cage questions, have you ever felt you should cut down your drinking? If they say yes, they score 1 point. Have people annoyed you by criticising your drinking? If they say yes, 1 point. Have you ever felt bad or guilty about your drinking? Yes, 1 point. And have you ever had an eye-opener to steady your nerves in the morning? So, like we said, a score of 2 or more suggests that somebody is at risk of alcohol withdrawal. Higher the score, the more at risk of alcohol withdrawal they are. It's important as well to establish somebody's illicit drug history, so you want to specifically ask about any use of cannabis, which is often really not considered to be an illicit drug. Heroin, cocaine, crack cocaine, whether they're using recreational drugs such as MDMA, ecstasy, amphetamines, ketamine, and these so-called legal highs, which are now illegal highs, and the umbrella term for them is novel psychoactive substances, and they have lots of terms. So, spice, black mamba, I can't think, but there's absolutely hundreds, literally, names for these so-called legal highs. And when you're asking about their drug use, you want to know the frequency, the route, the amount they use, and you can either use this in cost or weight, so how much they're spending on it, or what the actual gram is, and when they're last used. So coming on to the examination, you want to check some vital signs, and again, the vital signs that you're going to check will really depend on the presenting complaint, the past medical history, the drug history, and how they're presenting generally. But as a minimum, I think it's pretty reasonable to check somebody's heart rate, oxygen levels, respiratory rate, the Glasgow Coma score, or the AVPU, which is alert, verbal, response to pain, unresponsive, and check somebody's pupils, check the size, symmetry, and reaction to light. All detainees should have a general survey, and that's looking at how alert they are, their initial impression, Do they look well? Do they look unwell? Is there any noticeable odours? Do they smell of alcohol? Do they smell of cannabis? What's their gait like in walking to the medical room? What's their clothing like? Are they clean? Are they well presented? Are they dirty? Are the clothes dry? Are the clothes wet? Are they torn? Is there evidence of damage to the clothing? And what's the behaviour? As we said earlier, depending on the detainee's past medical history and the concerns from the police will determine the extent and nature really of the examination, of the clinical examination and the relevant systems, but it may include a neurological exam, respiratory exam, mental state examination, musculoskeletal exam, or looking at the abdomen or gastrointestinal tract. So, determining fitness to detain. When you're determining fitness to detain, you must not regard the custody unit as a mini hospital. Instead, you need to consider it as providing the same level of care and observation to that of a relative. So essentially, you're only going to accept detainees from hospital or keep detainees in hospital that would otherwise be suitable to be cared at home by close relatives. And it can't be stressed enough that the custody officers, the detention officers, cannot be expected to carry out any sophisticated clinical examinations. So essentially, a detainee is not fit to detain if their detention will have an unacceptable, detrimental impact on their physical or mental health. And some of the red flags that are associated with police custody. Now, these don't all necessarily mean that they're all automatically going to go to hospital, but these are red flags that things, that warrant further investigation and further scrutiny. This is going to be people with a breath reading alcohol concentration greater than 150 micrograms per 100 ml. So this is the alcohol breath reading, either on the intoxilizer or the handheld device. And that's because greater than 150 is associated with greater risk of death because of alcohol poisoning. Drunk and incapable, so somebody who is unable to walk and talk regardless of what their alcohol reading is. So if they blow 70 but they're drunk and incapable, well, that's much more important that they go to hospital. Suspected or an alleged drug overdose, blood sugar greater than 25. That would depend, on whether they were well, whether they were unwell, what kind of diabetic they were, whether you've got their insulin there. The FFLM provides some really great guidelines on diabetes. All stab wounds should go to hospital because it's just a small external wound and you do not know what damage has gone on inside. And anyone really who's currently an inpatient at a hospital, whether it's a medical hospital receiving medical treatment or a mental health hospital, you really need to interrogate whether it's fit that they should be detained in police custody. Further red flags is chest pain, somebody with severe alcohol withdrawal who is vomiting, hallucinating or fitting, any epileptic who has 2 or more fits or a poor recovery in between the fits should go to hospital, and anyone who isn't epileptic who has a fit should automatically go to hospital. Further red flags include those that are involved in road traffic collisions, specifically where a passenger has died, where the collision speed has been greater than 30 miles per hour. You would consider collision speeds that are much less than 30 miles per hour if the individual is aged over 60. Vehicles which were struck from the side, so that's called a T-bar collision, or hit more than one stationary object, so they've ricocheted. A vehicle in which the airbag has deployed. A vehicle which has rolled over. If they were unrestrained in that vehicle. Or if they were entrapped, or there was some kind of intrusion greater than 30 centimetres into the vehicle. And this can sometimes be difficult to know, so you have to get their collateral history from the police, whether they've got any body-worn video images of it, any still images of it, any photographs. If you've got any documentation from the ambulance service, you need to consider all this collateral history. So as discussed, the collision speed greater than 30 is a red flag, and this is just to illustrate how collision speed should be measured. So if you have one car travelling at 30 miles an hour, and then you have another car travelling at 25 miles an hour, and they crash head on, you have a 55 mile per hour head on collision. If a car is travelling 30 miles an hour and hits a stationary object, that is a 30 mile per hour collision. Head-on collisions, you are at risk of craniofacial injuries, hyperextension of the C-spine, some chest wall injuries, in particular an anterior flail chest or a sternum fracture. Deceleration injuries, these are what people are at risk of at speeds over 30 miles per hour, that's known as aortic transection. Posterior dislocation of the hip, a fractured femur, patellar fracture or a knee dislocation. This is an image of a T-bar or side impact collision, and these are the injuries that are associated with that, so some craniofacial injuries, a lateral rotation flexion of the C-spine, humerus fracture, lateral chest compression injuries including a flail chest or a pulmonary contusion, lateral abdominal compression injuries, splenic or liver lacerations, lateral compression pelvic fracture or a fractured femur. This is an example of an unrestrained driver in a rollover. I mean, they could have numerous injuries, absolutely catastrophic injuries from that. So you can see from that mechanism why somebody would have to go to hospital if their car rolled over, regardless whether they were restrained or unrestrained. Further red flags in custody are a main concern that does require intense scrutiny is head injuries. So particularly somebody who is drug or alcohol intoxicated, that's a big red flag. An individual who is over 65 years old, if there is a history of loss of consciousness, vomiting, if they present with a GCS that is less than 15, if they're amnesic regarding the events, they've got some previous history of some neurosurgery, or they're taking some kinds of anticoagulation therapy. Any one of these, I would be referring to the hospital for them to rule out some kind of traumatic head injury. These are again just some further red flags, in particular to head injuries, and these are all associated with a basal skull fracture. So that's bilateral periorbital hematoma, some rhinorrhea, which is clear fluid coming from the nose, subconjunctival hemorrhage, hemotympanum, which is blood behind the eardrum, so you'd need an otoscope to have a look in, some otorrhea, which is clear fluid coming out of the ears, and some mastoid bruising. So when you're delivering or formulating your care plan regarding fitness to detain, your first decision really is, are they fit to detain? Are they not fit to detain? The level of observations, these can change slightly, but according to the College of Police, they generally accepted that level 1, 2, 3 and 4. The frequency of observations, which can be 15 minutes, 30 minutes or 60 minutes, with or without CCTV monitoring of their cell. Can offer some comfort measures, or suggest even some comfort measures, such as food, drink, some clean clothes, a glass door cell, exercise yard, blankets, as well as collecting medication and identifying whether there's any need for further medical reviews or a medical rest period. So level of observations, generally considered 1, 2, 3, 4, 1 being the lowest, 4 being the highest level of observation. 1 is a general observation, and detainees can be visited either 30 to 60 minutes, but no longer than 60 minutes. And this is for those individuals who really require the minimum level of observation. They're low risk, no concern over level of consciousness, there is no need to wake when they are sleeping. Level 2, intermittent, is reserved for those individuals who are subject to the rouse and respond policy, which we'll come on to a second, and that's those who are either under the influence of drink or drugs, or have suffered a head injury, or you, for some other reason, worried about the neurological status. 3 is a constant supervision, and that's for those at a heightened level of risk due to self-harm, suicide, physical or mental vulnerabilities. Their cell CTV is constantly monitored. They remain to be physically checked every 30 minutes. And the highest level is level 4, close proximity, and that's the highest level of observations for those presenting with the highest risk of self-harm or medical concerns. They're constantly observed, constantly accessible at all times, with either one or more officers sat at the door constantly. Level 2 means that somebody is subject to Annex H or arousals, and this is what the police will do with the arousals. So they'll go into a cell to assess their level of arousability, can they be woken, their response to questions, and their response to commands. And if there's any reduction in those, either the HCP will be called or an ambulance called, and they'll be conveyed to hospital. Another thing to consider is whether you're going to arrange for the collection of medications. So medication should be continued in custody as it were if they were not detained, and this may mean the police making attempts to collect medication or arranging for medication to be prescribed, especially in the following circumstances. So those with asthma or chronic obstructive pulmonary disease, COPD, because without their medication, including their steroid inhalers, they might be at risk of exacerbation, which requires hospital admissions. Some asthmatics are incredibly fragile, and it's the same with some COPDs, they're incredibly fragile. Diabetes, especially for those requiring insulin, because without their insulin, they really are at risk of DKA, diabetic ketoacidosis, which can be life-threatening, or certainly some hyperglycemia. Epilepsy, well, without your epilepsy medication, you're at risk of fits or possibly developing status. Heart conditions, because there is a risk of deterioration in your heart condition requiring hospital admission. Those with HIV or AIDS medication, they're usually very time-specific. They're antiretroviral medications, so they're quite anxious to get those on time. Those with hypertension, because there is a risk of rebound hypertension. Although if somebody's going to be in custody for a day, 12 hours, generally your average length of detention, they may be okay. Parkinson's disease, because without their medication, which is very time specific, their Parkinsonian symptoms can worsen and deteriorate, and that will put them at real risk while they were in police custody. Those who suffer with a psychosis because of deterioration in their mental health. If you're on regular corticosteroids, if you're taking regular medication, regular steroids, an abrupt withdrawal of those steroids can make you very poorly and cause something called Addison's crisis. Anticoagulant therapy, so if you're taking warfarin or the new anticoagulants like rivaroxaban, you have a risk of venous thromboembolisms. Paroxetine, because of all the antidepressants, paroxetine is the one that is associated with quite a rapid withdrawal reaction. The other SRRIs, you should be okay to go a day or two without taking them. But if somebody's going to be detained for much longer, then really should consider getting their medication, because if they go without for a couple of days, it can make them quite poorly. And they are at risk of developing serotonin syndrome if there's an abrupt withdrawal over a prolonged period. Drug substitution therapy, so anybody who is taking Subutex, methadone, that medication should be continued within police custody if it can be. And antibiotics, if you're taking antibiotics, we know that antibiotic resistance is high. We need to be quite strict about antibiotic stewardship, so they should continue their antibiotics. So just looking at some of the common conditions that can present in police custody and how to care for them, or what care plans may look like. Somebody with asthma or COPD, you want to be authorising their own reliever inhaler, which is commonly salbutamol. If they don't have one, you may need to either prescribe or supply one where appropriate. It's up for the custody sergeant really to undertake the risk assessment to determine if it can be kept in their cell. If you have any objections to that or concerns, then they should be highlighted, but ultimately that decision should be the sergeant's. In the cases of severe asthmatics, brittle asthmatics, severe COPDs, or those with a prolonged detention, we should get the police to collect their preventer inhalers, and if they are poorly and we can't collect them, we should look at getting some medication prescribed for them. Those individuals who are on long-term oxygen therapy or some kind of home ventilation, either a BiPAP or CPAP, they should be placed on a level 4, so close personal supervision, to be able to afford to continue to have their treatment. And these people, you really need to rationalise their detention with the custody sergeant, because it is very unlikely that they'll be able to lie flat. They'll probably have to sit upright, so overnight detention can prove quite difficult. Sleep apnea. Sleep apnea is likely to be worsened by somebody who is intoxicated. Where a detainee has some continuous positive airway pressure or a CPAP device, this should be collected if not already. And again, you want to recommend close personal supervision overnight, because it has to be plugged into an electrical point, and that presents a self-harm risk. Sleep apnea, they are likely to have a decrease in breathing or have some apneic periods. That's normal for them, but they are going to start breathing again unless something else is going wrong with them. They aren't just going to stop breathing, not breathe again, unless something else has gone on with them. But it is important that they do get a good night's sleep, because without a good night's sleep, they're not going to feel refreshed. They are going to feel tired, and this could impact on their fitness to be interviewed. Again, like we discussed earlier, in those severe cases, you need to rationalise the detention and consider some alternatives for these individuals. Diet controlled diabetes. You want, with these type of individuals, you want to check a baseline blood sugar, regular meals. Unless they're unwell, there's no real need to be continuously checking their BMs or blood glucose. Tablet controlled diabetes. You want to check their baseline BM. Unless unwell, you consider just daily BM checks. Arrange for the medication to be collected. Verify the medication if you're able to, regular meals, and if they have any concerns that they're unwell, give them some food and refer them to the healthcare professional. Insulin diabetes, you want to check their blood sugars on admission or on detention, and then check between 3 to 4 times daily. It will depend really on their history. Arrange for the urgent collection of their medication, and if not, organise a prescription for their insulin. Verify the medication for administration, and if you're unable, that needs to be referred to a doctor. Regular meals, aiming for a blood glucose between 6 and 12. Supervise insulin after meals, and we should be using safety needles, and this is one example. This is the BD Auto Shield, and it's just a pen needle, and the needle pops out once it is activated by pushing against the skin, and the needle is retracted to prevent the detainee from using the pen as a weapon or a sharp, preventing accidental needle stick injuries. Again, if the police have any concerns that they're unwell, they should feed them and call the HCP. I think the biggest thing to be stressed to the police is that they should always feed them. The biggest worry is that they're going to become dramatically ill from a low blood sugar. So even if somebody's unwell because of a bit of a high blood sugar, giving them something to eat because they're unwell isn't going to do them much harm if they're already high. Better to be a little bit higher than low. Pumped insulin. These are people who are on a continuous pump. You want to check their blood sugar. I would suggest that these people go on a close personal supervision, so a level 4 because of the high risk of tampering. Regular BMs or blood sugar checks. Regular meals. Again, you want to aim for blood sugar between 6 and 12. And if a detainee is very high risk of suicide or is inappropriately interfering with the device to harm themselves, then I really would consider the removal of the device if they cannot be trusted with it, if they are interfering, I would discuss all cases with a senior, with the forensic medical examiner, and you will need to arrange for some kind of management plan with an intermittent short-acting insulin, such as Nova Rapid. But that wouldn't be something you would do on your own. That would be something you're going to discuss with one of your senior colleagues. Epilepsy. We want to establish their baseline, the type of fits that they have, the frequency of fits and the last time they had a fit. Wherever possible, you really want to collect their medication, verify it, and where you're unable to verify, again, I will discuss this with the FME just because of the risk of seizures in custody. Where you're unable to collect the medication, I will give some consideration to arranging for a prescription for them, either by the FME, one of your nurse prescribers, or seeing if the GP is willing to do you a short prescription. There's no need for routinely to be placed on level 2 R&R observations. In fact, it could be detrimental if you're working them up every half hour overnight, they're not getting any sleep, the seizure threshold could drop, could make it more likely for them to have a fit. Consider if they fit frequently, maybe a cambered cell, monitored cell, a low-level bench. If you don't have any low-level bench, a mattress on the floor, because depending on what facilities you have in your suite. And if fits, we're going to refer to the emergency department where we either give a medication to terminate the fit, they have a second fit, or there's a very poor recovery. Opiate withdrawal, this is a common presentation that's seen within the police custody setting. It is uncomfortable but relatively benign, can be fatal in extreme and untreated cases. Symptoms will usually develop between 6 and 12 hours after they're last used. Wherever available, we should avoid withdrawal by supervising community prescribed therapies such as methadone and Subutex. An opiate withdrawal is usually treated, at least initially, with between 60 and 90 milligrams of dihydrocodone 3 to 4 times a day. And the use of dihydrocodone in opiate withdrawal is off licence, but is well documented within the custody settings and some of the short-term healthcare settings. Opiate withdrawal, these are the things that you're likely to see on examination. That hyper-aroused, anxious, on edge, sweating, dilated pupils, some sneezing, running nose, yawning, tachycardia, piloerection, which is the hairs on the arms standing up, diarrhea, and some muscle pains or cramps. Usually it's measured using the clinical opiate withdrawal score or the COWS. Each area will have a different threshold of what is considered the treatment level. Alcohol withdrawal, again another common presentation within the police custody suite. Alcohol withdrawal has much more serious and potentially fatal consequences. The breath alcohol concentration on the handheld device or on the intoxilizer aren't really helpful with alcohol withdrawal because it's going to vary between individuals and could be high in some cases, depending on what their alcohol intake is. The National Institute for Healthcare and Clinical Excellence recommends the CEWA tool, both as a baseline and as a tool to monitor progress of medication. And treatment usually is diazepam or chloride epoxide. You can consider CCTV cell monitoring if you think there's an increased risk of fitting. So alcohol, and also it says benzodiazepine withdrawal here because they mimic each other, they work on the same principles. You're likely to see possibly some confusion, some irritability, if you're quite far down the line, seizure, red flag, some sweating, lots of agitation, hallucinations, red flags, tachycardia, nausea and vomiting being a red flag, and of course tremor. Tremor might start off fine, might develop into a coarse tremor. Again, NICE recommends that we use the CEWA tool, which is the Clinical Institute Withdrawal Assessment of Alcohol Score Revised, and that's approved by NICE, and it will depend on each area on what you would treat with, what you would consider to be acceptable. We mentioned earlier that chest pain is a red flag, and that's because it's associated with an aortic dissection, a pericarditis, a gastroesophageal pain, cholecystitis, pleuritic pain, or some kind of myocardial ischemia, such as angina or heart attack. So each patient has to be approached individually. Intoxication. Those individuals that are intoxicated, we want to have them on the level 2 as a minimum, so that's intermittent observations, rouse and respond, minimum of 30-minute checks, a low-level bench where possible. If not, consider a mattress on the floor and keep them on the side, and advise the detention officers to prompt them to stay on the side. We don't really want them on the back, especially if they're in drink, risk of vomiting, aspirating and becoming unwell. Check a blood sugar just to rule out that they're hypoglycemic, because this is one of the things that can mimic alcohol intoxication. Look for any evidence of trauma, document the absence of evidence of trauma, particularly you're looking for a head injury. Wherever you're suspicious, use the handheld intoxilizer just to check somebody's alcohol level. Somebody who's behaving drunk but doesn't smell of drink may be worth considering, because they may indeed have a head injury or some kind of drug intoxication. And looking at the research, on average, varies very widely, but you're looking to get a fall of between 8 micrograms per 100 ml per hour, but varies very widely. As we said, red flags: can they walk and talk? No, that individual is going to go straight to the hospital, to the emergency department. So this is why we worry about individuals blowing over 150 on the intoxilizer. So you can see marked out in red. The third column in is the breath reading, so don't worry about the BAC, that's alcohol concentration. We don't monitor that in police custody. But you can really see that when you're getting above 100, you've got general inertia, approaching paralysis, marked lack of response to stimuli, inability to walk or stand, vomiting, incontinence of urine or faeces. At 150, developing unconsciousness, depressed reflexes, a marked respiratory depression, and a marked bradycardia. And most deaths from alcohol are causing the levels between 150 and 219. Readings above 197 are associated with death from respiratory depression. Some individuals are going to tolerate a higher alcohol level than some others. Some are going to be walking, talking, looking sober, blowing 150. Some are going to look absolutely shocking, blowing 150. Some are not going to be able to provide because they're incapable. Drunk and incapable does not come to police custody, it goes to hospital. Your diagnostic criteria for diagnosing alcohol intoxication: well, there has to be some recent ingestion of alcohol. Some clinically significant maladaptive behavioural or psychological changes, such as inappropriate sexual or aggressive behaviour, some mood lability, impaired judgment, impaired social or occupational functioning, that develop during or shortly after the alcohol, and one or more of the following signs developing during or shortly after alcohol, so some slurred speech, incoordination and unsteady gait, perhaps some nystagmus, impairment in attention or memory, stupor or coma. And finally, the symptoms are not considered due to a general medical condition and are not better accounted for by another mental disorders such as trauma. As well as trauma, there's other pathological states that can simulate alcohol intoxication, such as metabolic disorders, particularly hypoglycemia, hyperglycemia, uremia, hyperthyroidism, some neurological conditions such associated with dysarthria, ataxia or tremor or drowsiness, such as multiple sclerosis, intracranial tumours, Parkinson's disease, epilepsy or acute vertigo. The effects of drugs, either prescribed or illicit, such as insulin, barbiturates, benzodiazepines, cocaine, a psychiatric disorder, hypomania, mania, high fever, or some carbon monoxide poisoning. Drug intoxication, overdose. These individuals want to be again monitored on a minimum of level 2 intermittent observations, that's the rouse and respond. If they have got drugs and alcohol on board, they're at much higher risk of deteriorating, so much lower threshold for referral to the ED. Body packers, body stuffers, that's individuals who swallow drugs or insert drugs into a body orifice prior to, during, after arrest, etc. They go to the emergency department for assessment. And don't forget, you can always use ToxBase to check any kind of toxin, drugs, household products, and that's available at toxbase.org. When we find that somebody's not fit to detain in police custody, more than likely we're probably going to be referring to the emergency department. So when you're referring to the emergency department, you want to consider who's going to transport, whether it's the police or the ambulance. And that might be something that you discuss with the police, with the custody sergeant, determining on how long the ambulance is going to be, whether they need any kind of monitoring or therapy en route, their condition, etc. You want to provide a documented clinical summary for the hospital using the SBAR tool, which is Situation Background Assessment Recommendation. That's quite well used now. Include the relevant details, provide some contact details for the ED on how they can contact you, and request the return of a discharge letter or some kind of discharge note. The Royal College of Emergency Medicine in conjunction with the Faculty of Forensic and Legal Medicine, in June 2016, produced the document Emergency Department Patients in Police Custody. And this is aimed at the emergency departments, and it's really stating that custody medical services are not structured to provide the level of assessment familiar to the emergency department, but really that we are there to provide primary medical clinical care. Patients requiring observations following a head injury will not receive the required level of care in a police cell. The level of risk for discharge should be as the same as returning a non-detained patient home. Goes on to say that each year, detainees in police custody die because of lack of recognition of or inappropriate treatment. Sometimes such deaths in police custody occur after assessments in the ED. Preventable causes of death in detainees include substance intoxication, missed head injury, alcohol withdrawal, and self-harm. Most custody officers responsible for monitoring detainees in police cells will have no more than basic life support training. Blood pulse, blood pressure, neurological observations such as GCS, blood glucose and oxygen saturations cannot be monitored regularly. 30-minute rousing to speech is generally the most intensive monitoring that can be achieved or offered in police custody. So if we go on just to have a look at some case studies, some examples. Look at number 1. We've got a 25-year-old male who's been arrested for being drunk and disorderly. He's normally fit and well, and on examination he denies any thoughts of self-harm. So for his care plan, do we think he's fit to detain? Yeah, he's fit to detain. He's in drink because he's drunk and disorderly, so we're assuming he's in drink, so we want to put him on level 2. 30-minute visits, R&R, and advise the police to rebook if there's any further issues. Number 2, we've got a 25-year-old male, again arrested for being drunk and disorderly, again normally fit and well, denies any thoughts of self-harm. He has got swelling and abrasion to his forehead. Care plan. Well, he's not fit to detain, is he? He requires assessment in the emergency department because he has a head injury and he has alcohol on board, we assume, because he's just been arrested for drunk and disorderly. So a head injury and intoxication equals a visit to the emergency department. Number 3, excuse me, we have again 25-year-old male arrested drunk and disorderly who is normally fit and well. When you see him, he's slurring his words, barely comprehensible, vacant, cannot stand without being held. He's currently being supported at the desk by the arresting officers. Care plan, fit to detain or not fit to detain? He's not fit to detain. He's presenting as drunk and incapable. He's not able to walk and talk, so therefore he again has a visit to the emergency department. Case study 4, we have a 77-year-old male arrested for historical sexual offences. He has a past medical history of cardiovascular disease, hypertension and osteoarthritis. His medications are at home, where he lives at home with his wife, normally independent, no carers. Fit to detain? Yeah, he's fit to detain. Level 1 observations for him, 30-minute checks, CCTV cell just to monitor him, collect his medication and verify, and advise the police to process as soon as possible. Case study number 5, we have a 34-year-old male arrested for breach of bail. He is epileptic, fits once to twice per week without aura, no warning. He's up to date with medication. Medication is at home. Care plan. Well, he is fit to detain. He doesn't need to go to hospital. Level 1 observations. 30-minute checks. No need to rouse just because he's epileptic, unless he was in drink or there was some kind of head injury. Could consider a CCTV cell if there's one available for him, considering that he fits once to twice a week. Collect or verify his medication, and advise the police that if he fits to call the HCP, to call yourself or to dial 999 when not available. Case study number 6, we have a 37-year-old female. She was arrested for missing court, so it's a warrant. Next court will not be for over 48 hours because it's a bank holiday weekend. She missed court because she was on ICU, where she spent 6 weeks because she was very poorly, and she has with her the discharge letter. She was on ICU with a bilateral pneumonia, developed a pneumothorax and an empyema. She has a past medical history of intravenous drug use, COPD and DVT. She's a 37-year-old lady, but she looks about 47. She looks 10 years older than the stated age. And she's run out of Oromorph, which she's taking. She's taking 10 milligrams of Oromorph every 2 hours, and she was on her way to see the GP when arrested to get some more. On examination, she looks unwell and she is in pain. Care plan. Well, this lady's not fit to detain. First off, she does have a genuine reason for not attending court. There is not enough medication for her. She's taking Oromorph 10 milligrams, along with some other medications that aren't listed here. There isn't a nurse available to give her Oromorph every 2 hours. It's concerning of over sedation. She'll be complicated by her intravenous drug use. Instead, spoke to the GP. She'd missed her appointment, but they agreed to see her now. The police agreed to take her to a GP, and she was given a summons to attend court at a later date. Case study number 7. 88-year-old female arrested for assault. She's normally fit and well and lives with her husband, but he's currently unwell in hospital. On examination, she's confused and sexually inappropriate. The impression with this 88-year-old lady is that she was not fit to detain. There was evidence of acute confusional state, and she needed to be sent to the ED to rule out acute medical problem. Case study number 8, it's the 25-year-old male who's been arrested for drunk and disorderly. This time he's an insulin-dependent diabetic. On examination he's drunk, but he can walk and talk. He has a blood sugar of 10 and his insulin is at home. This gentleman is going to be fit to detain, level 2 R&R, because he's, as documented, arrested for drunk and disorderly, and on examination is described as being drunk. So he'll be on 30 minutes R&R. Advise the police to give him some food now, collect his medication from home, recheck blood sugar in 3 to 4 hours while he's drunk, just to make sure there's no rapid drop in blood sugar. Case study 9, we have a 50-year-old male arrested for theft from shop. He has a past medical history of heroin, £100 a day intravenous. On examination he's shaky, sweaty, looks unwell, there's obvious piloerection and nausea. He is complaining of drug withdrawal and his clinical opiate withdrawal score is 15. Care plan for this gentleman is, well, he is fit to detain in police custody, level 1 observations, 30-minute checks, and administers some dihydrocodone as per your guidelines or PGD, along with any other complementary therapies such as some Paramedic, paracetamol, etc., ibuprofen, or antiemetic. Final case study number 10, is a 19-year-old male who's arrested for breach of peace. He's drunk, he fell down some stairs, several abrasions to the head. At the emergency department he was abusive to staff and he refused treatment. On examination you see him aggressive, he's swearing, he's unsteady on his feet and you're unable to fully examine him. Care plan. Well, he's not fit to detain. He needs to return to the ED to rule out some kind of intracranial pathology. Consider a different emergency department if that's an option. If you have a second or alternative emergency department in your city or town. If not, speak to the ED, explain your concerns about the need to rule out a head injury. If at hospital he refuses treatment, you need to see that they've assessed his capacity and documented that capacity assessment, and that information is fed back to you. Just some references from the from some of the early slides that we use, and that's all. We hope you enjoyed UKAFN's first webinar. If you're not a member, join now. Thanks ever so much. Bye bye.